Welcome to Orthopod, a podcast about the people of orthopedics and their stories. We understand that we all play many roles in our careers and lives, and it is these very stories that ultimately inform our successes and failures. Hello, everyone. Welcome again to another OrthoEvidence podcast. This is going to be an interesting but short one, focused on an update that we're giving you from a previous podcast focusing on quarterback injuries. With the Super Bowl just around the corner, in fact, Super Bowl 54, this got the San Francisco 49ers heading up against the Kansas City Chiefs. Remember, Sunday, February 2nd, starts at 6 p.m. Eastern Time. So let's take a quick look at the evidence in the end zone. For the San Francisco 49ers, we have Jimmy Garoppolo as their quarterback, 28-year-old, 6'2", 225 pounds, with an injury about 17 months ago. Now, this was an injury that required an operative reconstruction of the anterior cruciate ligaments. He missed 10 months from his playing season and has been back to play full-time 6 months ago. Now, let's contrast that with star quarterback Patrick Mahomes for the Kansas City Chiefs, 23-year-old, 6'3", 229 pounds, with an injury about 4 months ago. And you'll recall from our previous podcast, we spoke specifically about his non-operatively treated right patellar dislocation, treated with bracing, and ultimately missed about 24 days and has been back to play for 3 months. We're going to be joined very shortly with a call-in by Dr. Asheesh Bedi, reminding you again that Dr. Bedi serves as Chief of Sports Medicine and Shoulder Surgery at the University of Michigan. He's also head physician for the Michigan Wolverines and Detroit Lions, and a consultant firm for many other sporting teams. He's a surgical scientist with over 400 publications and 10,000 citations. Welcome, Asheesh.
Thanks for having me, Mo.
Barring the evidence that we have, if this injury had occurred in the same individual, so that, in other words, irrespective of age and let's say talent and even experience, Asheesh, which of the two injuries would put you at a greater disadvantage if everything else was equal?
That's a great question, Mo. And each of these, as you pointed out, comes with their own inherent set of concerns. I'll answer it this way. ACL injuries, when they happen, of course, are significant. They require a surgical intervention by definition because of the instability of the knee and inability to return. That comes, as we've already talked about, with probably a 9+ month recovery. Once you get 10 months out from the surgery and have had an uncomplicated, excellent result like Jimmy has, I think this injury starts to get to a point now where it's largely behind him, and that's reflected in these performance metrics that we just talked about. But I would maybe point out it's been an interesting year for me to watch in the NFL. If you look at even the playoffs, not every, but a lot of the quarterbacks who are performing at a top level were former ACL patients. Deshaun Watson has had bilateral ACLs. Ryan Tannehill with Tennessee had an ACL. Aaron Rodgers has had an ACL. So once you get to that point where you're out of that immediate risk for recurrence and have a stable knee, I think that's the injury that's behind them and that they can function for a number of years with a good outcome. I think the patellar instability event, in this case, particularly being relatively fresh just this past season, is a greater disadvantage. And the reason I do isn't because I think it's the worst injury. In fact, this is the one that has the opportunity to be treated non-surgically and may even be permanently treated non-surgically if Patrick doesn't have a recurrence. The worry for me, though, is that we know that there is still that significant recurrence risk looming for him, and that probably his mechanics are not entirely normal with a subtly unstable patella. And so I think if he twists, turns, takes the wrong hit, there's a real risk that could recur and take him out for the game, and then potentially, now being a second-time event, commit him to an off-season surgery. So given the timing of where these kids are with their injuries, as much as it sounds maybe a little counterintuitive, I pick the patellar instability event as the bigger disadvantage for this particular game.
Oh, that's a fascinating analysis, because you're absolutely right. I mean, the chances of a recurrence is certainly one. I would make the assumption that a patellar dislocation recurrence is probably more likely than having a re-rupture of his ACL, just based on what you've said. So I think for Sunday's game, that's going to be one thing that really would be a really important thing to watch for. In our studio, Seper Ekhtiari, who is the managing editor of OrthoEvidence, and Seper's done something that'll help us out here. He's scanned our database, our large database of evidence, to specifically look at outcomes following these two injuries, one for patellar dislocation and one for ACL injuries. And we're really going to try to look and dig deeper into the evidence. Hi, Sep. Thanks so much for taking a look at this.
Thanks, Mo. So the first thing we'll talk about is how are these ACL injuries treated in these elite football athletes? And the first study we're going to look at is a survey actually done by Erickson et al. And they looked at 267 NFL and NCAA football team physicians, so very relevant. And basically what they found is that almost everyone would use an autograft, 99%, and would use a single bundle graft, also 99%. And the vast majority preferred to use bone patellar tendon bone grafts in NFL athletes and NCAA football players. That was 86%.
So let me just ask you, Dr. Bedi, when you look at treating these elite athletes, and what is your preference? And is that aligned with what others seem to be doing, or do you have a different approach? And by the way, are you aware of what specific surgical treatment he received?
Great, Mo. I would say that the data from the Erickson study is fairly reflective of, I think, what is the typical practice for those caring for Division I professional football clubs. The preferences, there's always changes and trends in orthopedics, but largely what has stood the test of time has been patellar tendon autograft, single bundle ACL reconstruction. Lots of studies, including the Moon Group, have demonstrated that autograft is the gold standard. There was a period of time where double bundle reconstruction was explored, but beyond the biomechanical data, the clinical outcomes data never really bore out to be favorable to a well-done anatomic single bundle. So this is in line with what we would practice. The times where we sometimes explore other grafts besides the patellar tendon, relate to reasons where you may not choose to use a patellar tendon. It's either been used before, the patient may have a patella alta, a high patella or short patellar tendon, or a history of Osgood-Schlatter disease, and so reasons where you may need to explore other autografts. And in that situation, we sometimes look to the quadriceps tendon or hamstring tendon. Those have been successfully used in high-level athletes. It just tends to be the go-to is really the patellar tendon autograft.
Got it. So is that a reasonable assumption for Garoppolo's treatment, or are you aware of how he was treated? Because we certainly couldn't find out the specific surgical treatment. We knew that he had the repair, reconstruction, but we don't know much more beyond that.
I would share your sentiment. Not being involved in the care for Jimmy, I wouldn't know for certain, but I would say it's a very safe assumption that he had a patellar tendon autograft. Unless there was some medical contraindication. Most NFL quarterbacks, or frankly NFL athletes in general, will tend to have that as the graft of choice for a primary ACL.
Yeah, so we'll move on to what happens, when do these athletes come back to play, and what happens after they come back. So from that same Erickson study, the physicians felt that a minimum of 6 months was required. That was 90% of them. And actually 64% said that they wouldn't recommend the athlete wear a brace in-game. Looking at one more study by Lai et al., this was a systematic review and meta-analysis of elite athletes, meaning they're at the top of the highest possible level in the respective sports. It did include football players, but also other athletes. But they found that 83% returned to sport among these elite athletes, returned to their same level. And their timeline was 6 to 13 months with a 5% graft rupture rate.
So once again, that would put him in reasonably good stead, because from our tail of the tape that we reviewed, we had him injured about 17 months ago and back to play about 10 months ago. Asheesh, from your perspective, is there any concern with him, being back to only 10 months? It seems like it's well within the range that you would let these players come back.
Yeah, this is a great area, Mo, and an area that can benefit from great minds like you who do true evidence-based work. The return to play decision after ACL surgery, and frankly, so many things we do in orthopedics, right, remains a bit of a black box, right? We know there's an element that we rely on just for the tendon to heal to bone or the bone to heal to bone, but so much about the time of return to play is dependent on these other functional metrics. Are they moving well? Have they corrected their alignment with single leg landing and cutting and pivoting? So as you know, it's become much more mainstream to perform a so-called motion screen or functional motion assessment on an athlete before they return. Right. So the challenge here is, even though we use calendar months to get back to play, it really should be based on meeting milestones. That the athlete's quadriceps strength is back and their mechanical movement patterns are back, etc. And I would tell you what's interesting is it used to be we'd say at 6 months, if the knee examined well and they had a good Lachman and drawer, you'd let it go back to play. And I think as we've learned more, that number has pushed further and further closer to a year. Wow. So being 10 months out for Jimmy to be back is probably more now the norm. For me, if an ACL is functionally healed by 6 months, rarely are they leaving that visit and going back to playing NFL gameplay football. They're gradually working their way into activities, gradually being brought into practice in a controlled environment, and then it's not uncommon for it to be 9 to 12 months back. But his would fit in that range.
Okay.
With regard to bracing, that's an interesting area. There's not really one piece of evidence that I'm aware of that braces protect from ACL re-injury. We tend to use them. They may offer some psychological benefit. There's been some low-level evidence of braces protecting against MCL injuries in linemen and in skiing athletes. But the brace is, in many times, a preference of the athlete or the team physician or both, but not really rooted in evidence.
Got it. Okay, that's very helpful.
So interesting to note that Jimmy Garoppolo does continue to wear a brace in-game, and he's been very vocal about how it makes him feel better, for what that's worth.
Great.
So moving on to whether these injuries affect in-game performance. So there's a small study we'll look at by, again, Erickson et al. They found 13 NFL quarterbacks, so specifically the population we're looking at, 14 knees. This was a retrospective cohort. They found that 12 of the 13 athletes, 92%, returned to play in the NFL. And they actually matched them with paired matched controls of quarterbacks who did not have an ACL tear. And they found that there was no significant decline in their in-game performance after ACL reconstruction. We'll move on to Mahomes' injury now. As we mentioned, he had the patellar dislocation earlier this season. The evidence here is much thinner than the ACL evidence, as you would expect. But we'll start with a Cochrane review that we looked at in our previous podcast as well. But this is really the best collection of evidence on this topic. They looked at 6 studies, total of 344 patients, looking at surgical versus non-surgical interventions for patellar dislocation. And basically what they found is surgical management was favored in terms of preventing recurrence in the short term, 2 to 5 years. But this faded after 6 to 9 years, and there was no difference. And in terms of functional outcomes, again, surgery was favored early. Non-operative treatment was actually favored later on in the 6 to 9 year range. And adverse events only occurred in the surgical group, as we would expect.
So we now know what he had done, and he had a non-operative treatment. Would that have been your treatment? I think that was your advice when we had our first podcast on this, Asheesh. But I'm curious, again, knowing what happened, how you feel about that decision.
Yeah, most of the time, Mo, for an in-season athlete with a first-time patellar dislocation, my go-to management typically is non-operative. There are some exceptions to that. If an athlete happens to have this dislocation and knock off a significant piece of cartilage, so they have an associated osteochondral injury or loose fragment, then in that situation, you're pushed to have to treat the knee more aggressively with a surgical intervention. But most of the time, if it's an isolated dislocation without those associated factors of a fracture or a loose body, I would have reduced this and rehabilitated the knee, and then you have to counsel the athlete on what that means. They certainly have identified themselves to be at higher risk for recurrence, but usually if their desire is to return to play and they resolve their effusion and their quad is strong, you can often brace them and tape them and get them back to a reasonable level of function with some calculated risk that you're assuming for a risk of recurrence.
Well, that's great. And, at that time, we'd also polled the OE community. We had about 355 surgeons respond to that very question. How would you treat a first-time patellar dislocation in a high-level athlete? And just as you have educated us, 3 of 4 of those responses were supporting a non-operative management regime. So I think, again, generally speaking, that was the treatment that most would have at least opted for. So I'll have Seper continue on with the evidence review here.
So the next thing we're going to touch on is, again, what happens with these patellar dislocations when they're treated non-operatively in athletes specifically. And like I said, the evidence here is quite thin, but there are a couple of studies to look at. So one is by Atkin et al. It's a prospective cohort of 74 patients, mean age of 20, and they were all treated non-operatively, and 69% were able to return to their pre-injury level of sport. And this took, on average, 6 months for these athletes. On the other hand, Magnuson et al., a retrospective cohort study of 104 patients with a mean age of 24, also all treated non-operatively. this one was interesting. They found that basically return to sport was determined by whether or not there was a recurrence, which makes a lot of sense. So there was a 27% recurrence rate in these athletes. And among those who had a recurrence, only a quarter of them returned to play. While among those who did not have a recurrence, 86% returned to play.
So let me just ask you this one, Asheesh, and then we'll kind of ask one final bigger question as we move forward. But he was back, as I understand, in about 24 days or so. I mean, that seems fairly early. Would that be typical of someone or typical of an elite athlete getting back that quickly?
Great question, Mo. There's a huge range with these patellar dislocation events. When you first see them before the dust has settled, I typically counsel them that this does live in the range typically of 4 to 6 weeks. But there's kids who can be successful at rehabilitating and being back in less than that, and ones who take longer. And for me, it's about meeting sort of the functional milestones. They have to have really near complete or complete resolution of their fusion, or their quadriceps is still inhibited. They have to demonstrate great quad strength, particularly their VMO, because they're relying a lot on that to maintain stability. And then have no abnormal movement pattern or evidence of limited motion. If they've met all those milestones, then I feel reasonably comfortable, regardless of what the exact date is, that it's reasonable to return. All the other things that we're adding into the equation, the braces, the stabilization braces, McConnell taping, all of those things are sort of passive additions to try to add a little bit of augment to the natural dynamic stability from the muscle strength. So 24 days is a little bit, I think, probably on the earlier side, but maybe not surprising for an athlete like Mahomes.
Got it. Okay, that's really, really good. Okay, we're going to do a quick little comparison here of return to play performance. Seper's going to give us some stats here.
Yeah, so this is very interesting. Looking at how both of these athletes performed before and after their respective injuries, you'll see up on the screen there now, as passers, their passer ratings are very similar before and after injuries. But what I find really fascinating is both of their rushing games have actually been better since they've come back from injury, which is interesting because these are both, like we said, knee injuries that you would expect to affect their running game more than their passing game. But like I said, they've both actually been better in terms of rushing attempts per game. So they're running more frequently and they're actually getting more yards per game on the ground.
Now, is that typical in your experience too, Asheesh, where after an injury, we almost see an elevation in performance? And is that somewhat of a psychological boost they get, that they're trying even more aggressively to overcome their personal injury? I'm curious why that would happen.
That's a great question. I'd just be giving you a theoretical answer for Mo. I don't know. I tell you, I look at this kind of data, and when you have athletes like this who do this, it's a credit to them. I think, to your point, maybe psychologically they're pushing themselves and aware that they're overcoming an injury and being that much more deliberate in their effort. For me, the more typical pattern to see is if it's been rehabilitated well and they have good function and the treatment has been appropriate, you don't see a drop-off in their performance. So to me, this shows that, at least in the case of these two athletes, Jimmy has certainly gotten around the corner of his ACL and is now getting into the phase where that's a well-incorporated ligament. He has good normal movement patterns, and most importantly, confidence. I feel like these performance metrics sort of tend to be on the lower side, even if there's an objectively normal physical exam, if the player doesn't have confidence or has apprehension that it's going to recur.
I can't thank you enough for sharing your insights with us, Dr. Bedi, today. We are going to get this podcast up as soon as we possibly can, and we'll be in touch with you as well as we get going. But thank you very much for your time today. And I just leave it with you for any other final closing comments before we close up this podcast. Any thoughts?
No, thanks for having me, Mo. And I would love to be back for one of these when we're talking about the Detroit Lions in the Super Bowl. I'm not holding my breath.
Might be waiting a while.
Anyways, awesome. Well, thank you very much, Dr. Bedi. Enjoy the rest of your day, and we'll be in touch.
Thanks, Dr. Bedi.
Thanks, Mo. Thanks, everyone. Thanks,
Thanks for watching Orthopod. Stay tuned for more episodes.